Thank you very much. These are my disclosures. And as you mentioned, I would like to present a case with FH, mainly to stimulate discussion in the next session. So the case is a 53-year-old Caucasian man from our cardiology clinic, an accountant who was admitted to our coronary care unit with chest pain, suggestive of an acute coronary syndrome. Never smoked, had an average Australian diet, and you can make of that what you want. And his physical activity was limited to exercise twice a week. His family history is interesting. His father deceased at age 50 due to an acute MI. Father was a smoker. His mother was 80 and still quite healthy, but did have type 2 diabetes. Sister is healthy, but also has high cholesterol. And the children are healthy, and lipids were not tested when we first saw this patient. So this already points towards a genetic hyperlipidemia. Past medical history was unremarkable, and his current medication, he was not on any medication, and the ECG at arrival in our coronary care unit clearly showed an anterior STEMI, and as you would expect, the patient underwent primary PCI with a drug-eluting stent to his LAD. Now, where it gets interesting from a lipid point of view is his lipid analysis, and you can see that his total cholesterol was very high, his LDL cholesterol was very high, and to get milligrams per deciliter, we would have to multiply by 40 in this case. So very high LDL and total cholesterol levels, normal triglycerides, but also a significantly elevated Lp(a). So the diagnosis was a STEMI in a patient with dyslipidemia. And the therapy, high-dose statins, in this case atorvastatin, and all these other drugs that we give to virtually all our patients with acute coronary syndromes. Now, we have an elevated LDL, we have an elevated Lp(a), premature cardiovascular disease, possible FH, and the first question is what sort of LDL goal would you have in this patient? And we can leave that for the discussion section because after the first couple of talks today, I think we all agree that the LDL target in this patient would be very low, certainly less than 1.4 millimole per liter. This is a publication that we did a couple of years ago after the Improve It trial in Australia, where we already recommended an LDL goal of less than 1.5 in patients with very high risk of cardiovascular disease. We've talked about FH. Iana gave a brilliant presentation about FH, and she mentioned the diagnosis, and she did touch on the defects that can cause familial hypercholesterolemia, and I think most of us in the room are very well aware of these defects. We'll talk about genetic testing in the discussion section. But the thing that many people don't know is that the cholesterol in Lp(a) contributes to FH. And the cholesterol in Lp(a) is obviously very important in this patient as well. What Joanna also mentioned is that most of FH is not diagnosed around the world. No matter whether you look in Germany, Australia, Holland is a bit better because of all the lipid clinics and the people promoting FH diagnosis. But we are really lacking behind in diagnosing enough patients with familial hypercholesterolemia. And there's various strategies in how to achieve this. Now, you've heard about the Dutch lipid score, so I'm just going to mention this with the relevance of our particular patient. So he had a first-degree relative, which gives him 1 point. He does have premature coronary artery disease, which gives him 2 points. And his LDL was between 6.5 and 8.4. So this particular patient has probable FH and very high Lp(a). There's various models of care and guidelines around the world, and Gerald Watts in our region, together with a couple of us, has put together a model of care for Australasia. But this is very similar to what is done in the United States and very similar to what's done in Europe. So all these model of cares basically talk about how to diagnose, how to treat, which therapies to use, and about a multidisciplinary team that is often very successful in dealing with these patients. And that not only consists of doctors, but also lipid nurses, pediatricians, genetic counselors, and other people that are very much involved with FH care. Now, the other thing that many people are not very well aware of, and that's difficult, and one or two of the questions already hinted at that, is what to do with very high Lp(a) levels. And what we generally recommend is to aggressively lower LDL in people with high Lp(a) and increased cardiovascular risk. ACE inhibitors reduce Lp(a) in proteinuric patients, so this is interesting in hypertensive patients, obviously. Nicotinic acid does not have much outcome data with regards to cardiovascular risk reduction, but does reduce Lp(a), especially at the higher doses. LDL apheresis is probably the most effective current available therapy, but in some countries it's not available. But where it is available, the data is obviously very good, especially again in Germany and Italy and some other European countries. And then we are testing several new therapies for Lp(a) reduction, such as antisense therapy and other therapies that we'll hear about tomorrow. So what about our particular case? As you can imagine, atorvastatin 80 milligrams was not enough to reduce LDL sufficiently, so there was a significant reduction. So LDL was virtually halved with atorvastatin 80 milligrams. Lp(a) was not changed much, and statins really don't reduce Lp(a). So the next step to get to an LDL goal that we would all be happy with is to add ezetrol, which is exactly what we did. And one of the things that I see in Australia is that ezetrol is really underutilized in high-risk patients. So many of the patients that I get referred from general practitioners or colleagues of mine really come without ezetrol in the setting of FH. It's a very cost-effective therapy in Australia. Since it's become a generic, it's about 10 euros per month. I don't know the cost in Europe these days, but I'm sure it's not expensive either. It's not as effective as PCSK9 inhibitors, there's no doubt about that. But it does lower LDL on top of statin therapy, and that's exactly what we did in this particular patient. It's also worth pointing out that ezetrol does have some data, obviously, from the IMPROVE IT trial, and that there is a subgroup of patients which will respond better to ezetrol than you would expect from the trials. And they're generally hyperabsorbers of dietary cholesterol. So if you're a very good absorber of dietary cholesterol, your LDL reduction with ezetrol will be more than 15 to 20%, in some cases even 40%. So we added ezetrol to this patient, but as you can see from this slide, LDL was still nowhere near at the target that we would be happy with. So LDL after adding ezetrol came down by about 20% in this patient, or 18%, and the LDL is still 3.4, where we are aiming for approximately 1.4, 1.5 millimole per liter. Again, Lp(a) was virtually unchanged, which is expected because ezetrol also does not have an effect on Lp(a). And this is really where PCSK9 inhibitors come in, and we've already heard that very elegantly today about some of the outcome data especially, but also the whole trial program was mentioned. What PCSK9 inhibitors really do is reduce LDL further on top of statins and ezetrol, and this is especially important in high-risk patients and in patients with genetic dyslipidemias. So if you look at the population effect with PCSK9, you can see that you're going to shift more people into these lower LDL targets. And Erin has already elegantly demonstrated that on her talk. So how can we achieve an LDL target in this particular patient with the addition of PCSK9 inhibitors? In this case, evolocumab was added, and we got to a low LDL cholesterol in this patient. And this is the setting where PCSK9 inhibitors are reimbursed in Australia. So in Australia, if you have heterozygote FH, the government will actually pay also in homozygote FH for a PCSK9 inhibitor. And as you will hear again and again over the next 2 days, this is certainly not for everybody in primary prevention with slightly elevated LDL cholesterol. But if you are a patient with very high LDL, if you're a patient with high risk whose LDL is not a target, this is really where the strength of PCSK9 inhibitors lies. So very high LDL in patients with genetic dyslipidemias, very low LDL not at target in high-risk patients. And this is a consensus paper that we put together a couple of months ago in Australia, talking about PCSK9 and familial hypercholesterolemia. So we basically recommended PCSK9 in all homozygote FH patients, and in heterozygote FH patients with risk enhancers, such as elevated Lp(a), a calcium score more than 100 prior to statin therapy, family history of cardiovascular disease, or indigenous status with an LDL above 3.3 millimole per liter. In heterozygote FH patients without risk enhancers, we recommended an LDL of 4.5 to initiate PCSK9 inhibitor therapy.